Welcome to the Research Works podcast, brought to you in association with the Healthy Strides Foundation. Your hosts are Dr Dana Poole
and Dr Ashley Thornton, and we're here at the AusACPDM conference in Cairns, Australia, to interview world-leading researchers, clinicians and people with lived experience
to support your practice in being more evidence-based.
We are back at the Research Works podcast booth at AusACPDM. I am joined now on day 2 of recording by Amanda Khamis. Welcome, Amanda.
Thank you. Hello.
Amanda, we spoke to Israt Jahan yesterday, the other recipient of this very prestigious PhD platform. You also were one of the recipients of this platform. Congratulations.
Thank you very much. Wasn't Israt's speech brilliant?
It was beautiful.
I got very emotional.
It was incredibly emotional and, just an incredible body of work, as is yours. And I'm very excited to unpack that with you in this episode. But before we do that, let's tell everyone a little bit about you, as well as being the PhD platform recipient at the conference. You're a speech pathologist and postdoctoral research fellow with over 15 years experience improving feeding and communication disorders for infants with cerebral palsy.
Yes, makes me sound old.
You certainly don't look old.
Thanks.
So you work at the Cerebral Palsy Alliance Research Institute and University of Sydney.
I do, yes.
Is that right? Yeah. And the title of your PhD platform was Innovative Evidence-Based Assessment and Treatment of Oropharyngeal Dysphagia and Communication Disorders in Infants and Young Children at High Risk of Cerebral Palsy.
You did it. I think we're out of time now. It's a long title.
And I note that obviously Dana isn't able to be with us for this recording. She's left me with the trickiest title to pronounce. So
you did very well. I'm impressed. You could be a speechy yourself.
You can give me feedback later. So Amanda, this is such important work, and I'm really excited to hear, about this journey of a PhD, because PhDs, we throw that word around a lot, but PhDs are a journey, and often there's a journey before the journey. So can you tell us a little bit about this work, how you came to arrive at doing a PhD in this area?
Yeah, so I was a speech pathologist for probably close to 8 years, I think, at that point when I'd started, which was 8 years ago now. And I was getting very frustrated that a lot of the work, all of the work that we were doing as speech pathologists just had no evidence to support it, or very, very low evidence. And the ability to find that research was even harder. Yeah. So I've always kind of had an interest in the early intervention space, and we know from research in other areas that getting in there early is very important, the whole neuroplasticity approach. And I don't know, I wanted to try and contribute a little bit more. And you do informal bits of research and quality appraisals of papers and those sorts of things, and you just kind of you get defeated as a clinician when you come out every time with the same answer that more research is needed. So I thought, well, rather than spend my time coming up with the same answer every time I'm looking at the research, may as well invest that time into actually doing it. Yeah, actually doing some research.
Yeah, instead of waiting for the answers, you thought you'd go and get some yourself.
Yes, but underestimating how much time that would take.
And I think that's kind of a rite of passage for a PhD. Everyone starts off, with really high expectations of what is achievable within a PhD. You're going to solve all of the problems that you set out to solve, and, for a lot of the time that's true. Sometimes they're different problems to the ones that you set out to solve in the first place. But tell us a little bit about the evidence base for treatment of oropharyngeal dysphagia prior to you starting your PhD.
There's no response.
Zero.
We did a systematic review.
Yeah.
And we found 5 studies. There were very small samples of maybe 5 children, and very, very low quality. So even though it was low quality, we were able to find little threads of hope there that motor learning and neuroplasticity approaches and using those principles is the way forward, or certainly worth investigating further. Yeah. And so that was the seeds that planted in our brains of developing the Baby Eat program, which we did as part of my research.
Yeah. Okay, so talk to us about Baby Eats. What is it? How does it work? And
so
what studies were wrapped around it?
So it stands for, let me get this right, Baby Intensive Early Active Treatment. And it is all about, its foundation is motor learning and neuroplasticity, which as speech pathologists we have prior to this hadn't focused on from a communication point of view or from a feeding point of view. A little bit in the adult space for patients or people who've had a stroke, but definitely not in the paediatric world. And so it's an intensive approach where we tested Baby Eat against standard care, and it's a 12-week program that's quite intensive. So the first 4 weeks, I was the clinician for all of the research. I went out to see these families in their homes twice a week for 4 weeks, and then once a week for the following 8 weeks. And we were really trying to push these babies to do things that traditionally as speech pathologists we just wouldn't do. And it makes sense because we're all very worried about the risks of aspiration and that come with dysphagia. So we know that in cerebral palsy, aspiration pneumonia is the second most common cause of death. So obviously we need to be very careful. And clinically, I think we got to a point where we were being too careful. And so we were using lots of compensations like thickened fluids and purees, but they're not actually giving these kids opportunity to ever try anything else.
And challenge themselves.
So it's just like going to the gym, right? You challenge yourself at the gym and you do it in a safe way where you don't injure yourself, otherwise, you'll end up seeing a physio. But we wanted to be able to do this or see if we could do this and challenge these babies in a safe way that they were really enjoying and improve their skills that way by giving them opportunities, just incrementally challenging them, incrementally reducing the compensations they had, how thick the fluids they were, and give them little snippets of opportunity to try.
Yeah, fantastic. And then I suppose the next question is what did you find? What were your key results?
So it was a small sample. All up, we had 12 children, and it was a randomised controlled trial. So we had 6 children in the Baby Eat group and 5 in standard care. I think that's right. Maybe 7 in Baby Eat and 5 in standard care. And the results were actually really promising. So in terms of fluids, they were drinking better from a cup. They were drinking thinner fluids if they were on thickened fluids to start off with. In terms of their solids, they were eating more advanced foods. And even though we were challenging them, none of them were at risk of aspiration. Nobody had aspiration pneumonia. There were no hospitalizations. Even though they were having more advanced foods that in many cases needed a lot more chewing, they weren't any less efficient with their meal times. They were, and it didn't impact how much volume they were eating or their nutritional intake either. So even though we're challenging them, there were no risks in our study. So that was really encouraging.
Fantastic. And one of the things I took away from what you talked through in your platform was how enthusiastic the families were about being involved in the program as well. Can you talk a little bit about that?
Absolutely. Thank you. I couldn't agree more. And one of the measures that we used was the Feeding Swallowing Impact Scale, which really looks at how stressful meal times can be for families and the impact on their quality of life and just daily living. It takes so much more time to prepare a modified meal for a baby, or your meal times last for an hour or 2 hours long sometimes. So in this measure, we found that it tests 3 different domains, and across all 3 domains, we saw improved results and better results in the Baby Eat group than we did in standard care.
That's fantastic. And I think that's really reassuring for families as well, given what you talked about before in terms of the risk factors and, things that I imagine families have in the back of their minds when it comes to risk of aspirational pneumonia and things like that. That's really quite reassuring, isn't it?
Yeah, it absolutely was. And I can't tell you how lovely it was to be invited into these families' homes and share meal times with them and to see the impact and to see the bonding happening and connection because meal times were less stressful for everybody. It was really lovely to see that impact.
One of the things before we wrap up I really wanted to talk to you about is the translation of these overarching principles of, evidence-based therapy, neuroplasticity. Can you just talk briefly about how you incorporated that into this program? Because as you said, it's something that I think we're all familiar with as clinicians, but not something that is perhaps historically been applied in the speech pathology world.
Yeah, and it was a challenge, and we looked at the adult literature, and there are some motor learning and neuroplasticity approaches there, but you need to be able to follow instructions. So, swallow really hard or don't swallow until I kind of tell you. And when you're working with babies under 12 months, you just can't.
No.
And so it took a very long time to try and come up with alternatives to this. And so we had to kind of think laterally and also think about what we've been doing clinically and talk with my colleagues and teams around what other ideas are out there. How can we try and translate this? And we ended up coming up with a very strategic and strict protocol, which we haven't published, but once we do a bigger study, we will. But it's essentially just about, and to be honest, it's not really rocket science. It's just about reducing the level of support that we give them and giving them small opportunities, a couple of mils of thin water at a time, or rather than a super slow flow teat, try them with a faster teat, or don't pace them with a bottle as often as you used to. See how they go. And when you reassess them as frequently as we were, because we were seeing them frequently, you can actually try and test them with some of these. And if it works, great. You can try and practice that skill a little bit more in these small increments. If it doesn't, maybe give them some more time and then try again. But the key here was how often we were seeing them, because it allowed us to reassess them quite frequently, as opposed to traditionally where you see them maybe once every 3 months.
And there's just not that opportunity to try and embed some of these strategies, is there?
That's it, And we saw within the standard care group that 2 of the kids didn't get any services in 3 months. And the maximum within 3 months was 4 sessions. It's just quite dire traditionally.
It is,
I think the big part of it is seeing them frequently to give them opportunities to see whether they're safe to try small challenges.
And I think it's something that we've spoken about a lot at this conference, that task specificity and meeting children where they're at and really taking the time to think that through, and as you say, try out those different strategies and don't be afraid to pivot if things aren't working out how you originally thought they might, or how that child is on that day.
Absolutely. And I think I don't know how it is in your world, but in the pediatric feeding space online, and social media is such a big influence for a lot of families, and they're seeing some of these interventions that aren't task specific. So looking at chewy tubes and vibrating tools and pacifiers, and they don't as closely align to motor learning principles as a direct approach where you're actually using food or fluid that are whole tasks. And so we just gave these kids the opportunities, if they can safely manage food and drink, give it to them. Give them the opportunity to try. There's no point practicing with silicon when you can practice with real food.
So, that social media piece is something that we speak about a lot as well, and I'm so pleased you brought that up, because I think, this work that you and the team are doing is the start of something, really big in speech pathology space. So congratulations for that. Talk to us a bit about where to next for you and this work. So you kind of hinted at something, a bigger study that will be coming out soon.
This is the pie in the sky, and to be honest, I'm kind of in this state of trying to figure out if it's the chicken or the egg first. So one of the challenges with the study was the outcome measures that we have in speech pathology in this age group are pretty terrible. So we're faced with the challenge of, okay, do we invest our time into creating an assessment tool that will be more reflective and responsive to change over time, and that can be used from birth up till at least 2 years old? Or do we go straight into a larger randomised control trial so we can see whether this intervention is actually, has legs that will work for more people? We're trying to do both simultaneously. And I've spoken to ISRAT a lot over the past couple of months about how something like this might translate to low middle income countries as well. So my hope is that we get something that will work cross-culturally, irrespective of resources, because it's not an expensive intervention. You don't need specialised equipment. It's just food or drinks. And so, I have lots of ideas, but the assessment piece is our main priority at this point in time, and trying to get some more support into low middle income countries. And then hopefully one day we can do a bigger baby eat.
Yeah. Oh, that sounds amazing. And I absolutely love the synergies between your work and ISRAT's work, and how those two bodies of work might join together at some point in the future. It's pretty beautiful stuff. So thank you so much, Amanda, for joining us, and congratulations again on your PhD platform. It was a magnificent presentation. To everyone listening, thank you for joining us, and there's plenty more to come from the conference. Bye.
Bye.